complication of the diabetes? Diabetic foot. What's the magnitude of the problem? 15% of all patients with the diabetes at some time in their lifetime. See the incidence. If you see the 12.5 crores of the diabetes in India, 15% of all patients with the diabetes at some time in their lives. So very, very high in numbers. Okay, more than 1 crore or nearly 2 crores of the individuals are having the diabetic foot problem. Prevalence of active foot ulceration varies from 1% in Europe, North America to more than 10% in Africa. Incidence of foot ulcers in diabetes is approximately 2% per annum. Foot problems account for 25 to 50% of all hospitalizations in patients with the diabetes. So it's an important cause for hospitalization. It is the leading cause of non-traumatic lower limb amputation in the world in general and in India in particular. Over 1 million lower limbs are lost due to diabetes annually. So imagine these are all relatively middle-aged group or younger age group, not the older individuals. Every 30 seconds, a lower limb is lost somewhere in the world due to the diabetes. In India, over 1 lakh lower limbs are lost due to the diabetes annually. 75% of these amputations are in neuropathic feet with secondary infections which are potentially preventable. It is almost a preventable condition, diabetic foot. See the predisposing factors. Large and small vessel disease. On one hand, vascularity. On the other hand, the chronic sensory and motor neuropathy. So vasculopathy on one hand and neuropathy on the other hand. And then there will be the uncontrolled diabetes, top of it. So any trivial trauma will lead to ulceration and finally amputation. Again, autonomic neuropathy. So people with autonomic neuropathy, we discussed about the several symptoms and signs of autonomic neuropathy in the heart, can, in the gut, in the genitourinary system, erectile dysfunctions, etc. In the same way, the skin. So what will happen? There will be the dryness of the skin. So in the dryness of the skin, so again, there will be, because of the dryness, the skin is not able to prevent the entry of the organisms into the body. So they lead to, even a trivial injury in an autonomic dysfunction individual will cause a lot of infections. Local deformity, your clottos, your motor neuropathy, etc. And susceptible to the infection in some places. So improper cutting of the nails and etc. Or not a proper shoe they are using it. So definitely they will cause some damage to these toes and the foot, will lead to the lot of the infections. Leads to lack of protective sensation. So the foot becomes insensitive. Leads to injuries that remain unnoticed for the long time. Motor neuropathy can cause loss of power of muscles of the thighs, legs and the feet, leading to the development of the hammer toes, bunions and other foot deformities. Deformities lead to the development of abnormal pressure points over the foot where calluses can develop. They can predispose to the development of the Charcot foots, that is the neuropathic foot, auto-digestion of the bones. If you take an X-ray, all the bones will be auto-digested. So there will be instability of the foot. So there may be, you may use the total casting of the foot, etc. So they are the Charcot's foot or neuropathic foots. Autonomic neuropathy leads to reduced sweating, dryness of the skin and fissuring. Can also lead to the microvascular dysfunction, heavy shunting, with reduced perfusion to the areas in the need. So these are all the predisposing factors caused by the neuropathy to cause more and more diabetic foot infections. See the callus. Due to the repetitive mechanical forces of the grit or due to the pressure from the ill-fitting footwear. So these calluses, so finally they will end up with diabetic foot ulcers. Callus develops only if the blood flow is adequate. Thick callus can press on underlying soft tissues and cause the ulceration. If callus is not removed in the time, the tissue necrosis occurs, leading to the formation of a trophic ulcer. See these ulcers. These in the neuropathic foot develop at the pressure points, sensory neuropathy, toe ulcer, erosions on the dorsum of the foot, claw toes, hammer toes. So these are part of motor neuropathy. See the veins, distended veins on the dorsum of the foot in a patient with diabetes and autonomic neuropathy. Charcot's neuroarthropathies, a relatively painless condition. It's a progressive and degenerative arthropathy of single or multiple joints caused by an underlying neurological defect. Prevalence 0.08 to 13%, found in both type 1 and type 2, usually unilateral, 1/4 they are bilateral, occurs in individuals with diabetes duration more than 12 years. So in India, more of the people are having diabetes duration more than 20 years, 30 years, etc. because we get diabetes at an younger age group. So 12 years diabetic history is not a big thing in our Indian population. So this is the neurotraumatic and the neurovascular. Diabetes is the primary disease. See sensory motor neuropathy and autonomic neuropathy. In sensory motor neuropathy, the proprioception, pain, vibration, intrinsic, etc. In the autonomic neuropathy, sympathetic failure, increased AV flow, shunting, etc. So these Charcots, you have the acute Charcot and the chronic Charcot. In acute, heart, swollen, erythematous foot, bone crepitus, sometimes positive, pain conspicuous by its mildness or the absence. Patient may recall the minor trauma in the preceding days or the weeks. There is a history of the trauma. Common sites midfoot, followed by the metatarsophalangeal joints like your gouty arthritis and the ankle joint. A chronic Charcots, patient presents with various deformities including the flat foot, rocker bottom foot. So often we see the chronic Charcots rather than the acute Charcots. So acute Charcots is an emergency, will come up because the foot is too hot, the foot is swollen, the foot is very tender. So obviously they visit you and you get an X-ray done and you can know whether all the bones are there or not, any autodigestion of the bones are there. Then we can diagnose the Charcots. But in a chronic one, so unless you examine the foot, you don't know whether the fellow is living with a chronic Charcot foot or not. So chronic Charcot foot again a complication for your uncontrolled diabetes. So usually the vascularity of the foot will be good and pulses may be bounding because it is more of neuropathic. It is more of neuropathic. In neuropathic, the vessels will be good. Whereas in vasculopathy ulcers, so the vessels will be blocked. So there will be not palpable dorsalis pedis or posterior tibial, not palpable. See the Charcots, front one, acute, redness, swelling, etc. See the fractures, auto fractures. Even he doesn't know that he had any injury also, a trauma also. Without a history of the trauma also, if you take an X-ray, so you will have a fractures, erosions. So this is very common with the Charcot's foot. PAD, now with atherosclerotic occlusion of the lower limb arteries, decreased delivery of oxygen and the nutrients required for the normal function, usually gives history of intermittent claudication. The rest pain may indicate the critical ischemia. Symptoms of intermittent claudication may be absent if there is a concomitant sensory neuropathy. Loss of hair, atrophy of the skin and the nails may be seen. Poor healing of the foot injuries, infections or ulceration can lead to necrosis and finally gangrene and then posted for amputation. So the peripheral arterial disease, one should be very careful about it, and you get the ankle brachial index. So Doppler, so peripheral Doppler, ankle brachial index, the normal is less than 0.9. If it is less than 0.4, it is very critical stenosis will be there. See the toe gangrene. In the first picture, the third toe. In the second picture, the second toe. In the third picture, and the second and the fourth and the fifth. And see the lower pictures. So discoloration, excoriation, cellulitis, gangrene, already toes, great toes lost. So it's very unfortunate foots. We often see such foots in our OPs and in our inpatients, and most of these people, they require amputation very near future. So these are the differences between the neuropathic and the ischemic. Site of the ulcer, neuropathic is the pressure point at the bony prominence, where the ischemic usually on the dorsum, at the tip of the toes or the between the toes. This is a very important definition, differentiating point as far the site is concerned. So what are the sites of the pressure on the bony prominences? You can see the neuropathic ulcers, whereas the vascular ulcers mostly on the dorsum of or the tip of the toe. The pain in the neuropathic usually the nocturnal, the ischemic claudication pain when the patient is mobile for some distance and he takes the rest, the pain will subside, and at later time when the critical ischemia is there, even the rest pain is also possible. But first time in all the ischemic there won't be any rest pains. Whenever they walk, they get the pain because of the peripheral vascular disease. At a later time they will get the rest pains. Blisters are very common with the neuropathic ulcers, whereas they are rare with the ischemic ulcers. Deformities are common in the neuropathic because neuropathic means sensory neuropathy, motor neuropathy and autonomic neuropathy. So the deformities with the motor neuropathies are very common. In the vascular you don't find any deformities. Prognosis in neuropathic, they heals faster because the vascularity is there. Whereas the vascular ulcers, ischemic ulcers, they don't heal because the vascularity is very poor. So heals slowly, may lead to gangrene if left neglected. Pulses, in neuropathic ulcers the pulses will be present, whereas in vascular ulcers or ischemic ulcers they will be absent. Temperature of the foot, neuropathic warm and ischemic cold, and the treatment, pressure redistribution in the neuropathic ulcers and revascularization in a ischemic ulcers. So it's a very important differential points between your neuropathic foot and the ischemic foot. See the features of the neuropathic and the ischemic ulcers. See the neuropathic foot ulcers where the ulcers are on the points of the pressure. So these two are the points of the pressure. When you walk, the foot touches on the ground in these places. So you see the ischemic ulcers on the dorsum of the foot or on the tip of the toes. So this is the typical ischemic. So the barefoot walking predisposes to a mechanical and the thermal injury, shoe bite from ill-fitting footwear, home surgery for the corns and the calluses, improper cutting of the nails, insect or the rodent bites. So all these are common in the people with barefoot walking in uncontrolled diabetic individuals. So these are the evolution of the foot examination. So general appearance, monofilament, your ankle jerks, your vibration sense, they are very important examination. See the ankle jerk, vibration sense, tuning forks. So that helps in the clinical diagnosis. Probe to the bone test. A gritty feel to the base of the ulcer suggests osteomyelitis. It looks so simple, the ulcer, but you see the depth of the ulcer. So that probe touches the bone. So that shows already some element of osteomyelitis is there. So osteomyelitis means bony involvement. So the duration of the treatment will be very, very high. Very long duration, because you have to control the osteomyelitis also. Sometimes you have to sacrifice the toe. So amputation of the toe is also possible for them. So investigations in the diabetic foot. So metabolic investigations. So what are all the metabolic investigations? Your HbA1c, your renal functions, your lipid profile, your thyroid profile, etc. And X-ray foot is very important, and pus culture and sensitivity is very, very important, and peripheral Doppler study to know the vascularity of the patient. Then biothisometry, Doppler, ultrasound, and finally angiography, provided if it is a vascular ulcer. So this is a Doppler ankle brachial index, biothesometer. See the diabetic osteomyelitis, Charcot's foot, you are not seeing any bones there. So the neuropathic foot and the neuroischemic foot. Neuropathic foot, a warm, well-perfused foot with the bounding pulses and distended dorsal veins. So by seeing the foot, we can say whether it's a neuropathic foot or a vascular foot. A callus may be seen, more of neuropathic. Distended dorsal veins, neuropathic. If you touches the pulses, they are bounding pulses. Pulses are well felt, it is a neuropathic. Deformities like Klatos, again the motor neuropathy. Prone to Charcot arthropathy, can develop the necrosis if severe infection supervenes. On the other hand, neuroischemic foot, a cool, a pulseless with poor perfusion. Usually neuropathy coexists, then readily develops into the necrosis. Plantar ulcers are the rare, ulcers develop at the edges of the foot. Here a female 48-year-old, diabetes for the last 12 years, injured her left leg 15 days ago. Now she complains of pain and swelling of the left foot. See, now she is 48-year-old, but for 12 years history of the diabetes life. So very unfortunate Indians getting the diabetes at 20 plus or 30 plus. On examination, she is not able to feel the monofilament or the vibration sensation. Her ankle jerk is absent. See the abnormalities. So tested with the monofilament, tested with the vibration cells, used your ankle jerk. So all these are negative. Both dorsalis pedis and posterior tibials are absent. So which is it vascular or is it neuropathic? Patient has deep ulceration with infection and osteomyelitis on the plantar surface of the left foot. So how will you grade these ulcers? What is your line of your management? So these are the staging of the diabetic foots. Stage 1, stage 2, stage 3, stage 4. Stage 1 normal foot, stage 2 high risk, then ulcerated, then infected, then necrotic, and then finally unsalvageable foot. So these you should know that. Whether the foot is at risk, whether first simply ulcerated, or is it infected, or is it necrotized, and finally unsalvaged or gangrenous. This is the Maggot-Wagner's classification, very famous classification on the foot ulcers. Grade 0, 1, 2, 3, 4, 5. So 0 foot at risk, 1 superficial ulceration, 2 deep ulceration, 3 osteomyelitis, 4 localized gangrene, 5 extensive gangrene. Okay. So if you see a case of the grade 4 and the grade 5, so definitely the amputation of the toe or amputation of the foot is needed. So once it is up to 3, we can salvage the foot because of this deep ulceration or ulceration with osteomyelitis. So possibility of not going for the surgery is a possibility. But once it is a localized gangrene or the diffuse gangrene or extensive gangrene, so definitely surgery has to be done to him. So this is the University of Texas classification. A multidisciplinary approach is required for the foot care because the causes for the foot complications are multifactorial. So it's an integrated approach. You are the leader as a physician. You need the help of a general surgeon sometimes, vascular surgeon sometimes, orthopedic surgeons, educators. You should behave like an educator, orthotist, interventional radiologist, podiatrist, microbiologist, etc. Okay. So principles of the management: normal foot, prevent the development of the risk factors, glycemic control, lipid control, and good foot care practices. High risk foot, proper footwear, corns and calluses removal, metabolic control, education, and again good foot care practices. So these two are very important. So a normal foot and high risk foot. So control the diabetes and good foot care. A 60-year-old lady, the diabetes for the last 20 years. So she got the diabetes at the age of 40 years. Present with the painless swelling of the ankle joint with the bounding peripheral pulses. So what is your diagnosis? Charcot's. Acute or chronic? Chronic. It's a painless. Okay? Very long duration. Surgery is contraindicated in the acute Charcot foot, even though it is a tender or swollen, etc. See the vessels here. See the block. So post-operative. So there is a big block. They have put one stent there. Now the circulation is good. So revascularizations. After the revascularization, grafting is very much needed. Chronic extensive ulcers may be healed by the skin grafting. So the management of the foot, microbiological control, wound control, vascular control, mechanical control, and metabolic control. Microbiological control, your culture and sensitivity. Classic signs of infection may be masked by the presence of vascular disease or the neuropathy. Untreated infections can progress rapidly and may lead to loss of the limb or even the life also. Hence, empirical antibiotic therapy is indicated in a significant proportion of the diabetic foot ulcers. Once it is a diabetic foot, don't wait for the culture and sensitivity. So immediately start with an empirical antibiotic therapy and then wait for the report, and then you can change the other antibiotics. So these are all the empirical antibiotics, non-limb threatening, and life threatening. So non-limb threatening, you can use the amoxicillin, clavulanic acid, metronidazole combination, or ofloxacin and metronidazole, or cephalosporin plus metronidazole. So metronidazole is a must for anaerobic organisms, and amoxiclav or ofloxacin or cephalosporin. That is for the non-limb threatening or the simple foot ulcers. And the limb threatening, so how to use? Here three: amoxiclav for gram positive, amikacin for gram negative, and metronidazole. Or in the amoxiclav place, you can use the ceftriaxone, that is our monocept deficiency, amikacin and metronidazole. And then you can use the 5% tazobact plus amikacin plus metronidazole. Or you can use for the ofloxacin plus amikacin and metronidazole. Or cefoperazone sulbactam. Okay. In the life-threatening, you can go for the imipenem, celastine, etc. Meropenem. See the superficial infection, shallow ulcer without the purulence, complicated with a good support system, metabolically stable. Limb threatening, osteomyelitis, mechanical control, so the total contact control, cast. So this is for your Charcot's foots. The chronic Charcot's foots, you have to give the total contact cast. Offloading. So 64-year-old lady, admitted with history of ulcer, discharging the pus from the big toe, swelling of the right foot and the leg, and fever of 1 week duration. Type 2 diabetes for 15 years and is on OHS. She has uncontrolled diabetes with cellulitis leg and sepsis of the foot. Treated with insulin along with OHA, antibiotics based on the culture. Her fever subsided, swelling decreased, diabetes status and ulcer foot controlled. Discharged with OHA and other supportive measures. Don't hesitate to initiate insulin therapy during the sepsis. Okay, always indicated in the sepsis. Otherwise, if you don't use the insulin, you keep on using the OHS, then the sepsis will increase in its capacity and definitely leads to death. Metabolic control is good. So monitor the blood glucose at least 4th hourly. In patients with OHS, switch over to the insulin. Increase the insulin doses to cover the persistent hyperglycemia. Maintain adequate fluid intake and respect the kidneys. So without seeing the urine output, if you increase the intake, so the people will end up with acute pulmonary edema. Necrotic foot, severe infection can lead to necrosis, which is usually wet. Surgery is almost always indicated. So we have to have a surgical consultation for all these necrotic foots. In the neuroischemic foot, necrosis is due to macrovascular occlusion and usually dry. As far as possible, surgery is delayed till the vascular control is achieved. So wet necrosis, ask the surgeon. In the dry necrosis, wait for the surgery. Surgical options for the necrotic foot: operative surgical debridement, facilitated auto amputation, larval therapy used in the West. Aim for the tight glycemic control in every case. Not only the glycemic control, metabolic control. So I stop here, I think. So these are all the custom made footwears, MCR, MCP. So this is a very important 10 commandments of the diabetic foot care. What are they? Don't walk barefoot. Number 1. Okay. Inspect the feet daily for the blisters, wounds, bleeding, foul smell, and increase the temperature at pressure points of the feet. Do not apply hot fomentation or cold compress, electric heating pads, strong counter-irritant ointments to the legs and the feet. Use correct footwear. This is a very important one. Choose your footwear after consulting your doctor. Always wear footwear with socks with a loose elastic. Don't walk bearing weight on the affected foot in case of the presence or wounds after the surgery. Do not sit cross-legged for a long time. Don't remove footwear during travel and place your feet on hot subjects like silencers. This can cause the burns. When they are moving on the two-wheelers, most of these diabetic foot ulcers, so the silencer burns is also very common. Cut the nails regularly. Nails should be cut straight across. Don't cut corns and calluses with the blade or the knife. Home surgery is always dangerous. Clean the feet twice a day with soap and water. Wipe the web spaces dry and apply softening agents to feet. So these are the 10 commandments of the diabetic foot care. Saving the foot. Conclusion: early diagnosis, proper evaluation, management of the diabetic foot, and leading to the reduction in the amputation rates. So I stop here. Thank you.